would you still start him on heparin, or no, or all of the above, none of the above? I mean, this is how you make multiple choice questions. You ask a question and you get several answers, and one of them is correct. Pardon? Yeah. Yes, in aortic valve, the risk of valve seizure is very low, even if it is a prosthetic valve. Ball valve, they are low risk. So even if you stop the warfarin and not put them on anticoagulants, it still would be okay. A lot of the time we do put them on heparin. If it's a tissue valve, you don't need to bother then you are safe, right? So this is a challenging case. You need to optimize his anti-anginal therapy. You would want to, if he's a diabetic, you need to, if he's on insulin, then he would need sliding scale insulin or a GKI infusion, which is a 10% glucose solution, 500 ml bags, 10 units of insulin in that, and 10 millimoles of potassium chloride given at 100 ml per hour. You can either do that, but considering his cardiovascular status, giving him extra fluids might compromise him. So you may just put him on sliding scale insulin. If he's on tablets, you just ask him not to take his oral hypoglycemic agents and monitor his BMs. Okay. Regarding anticoagulation, now, what sort of dosages of heparin would you write, or whether you would get subcutaneous heparin or intravenous, or what do you do?
Intravenous, because it has short lifespan.
Okay.
Heparin infusion to maintain the liquidity.
Yeah.
In
this particular case, before the procedure, we actually plan, because when we are to shift the patient from the warfarin, it may take 3 to 5 days actually to INR to correct. And for that period, this kind of patient should be hospitalized before the procedure.
Yeah.
And his bleeding definitely must be happening. And before 12 hours before the procedure, he can be also subcutaneous heparin, low molecular weight heparin. But 6 hours in the 12 hours in the procedure, he should be on the IV heparin, so that it can be reversed within minutes and again restarted within few minutes and hours after the procedure.
Okay. I mean, that is all correct, absolutely. I mean, that's what we used to do standard, put them on IV intravenous heparin, admit them 4 or 5 days before the procedure, stop the warfarin, put them on intravenous heparin, and stop the heparin on the day of the procedure. So, just before going for the endoscopy, because heparin has got a short half-life, and you can, as soon as you switch it off, the anticoagulant effect goes. Nowadays, at least in UK, what we do is, we were using the same protocol as you suggested, but we use subcutaneous heparin, which is enoxaparin or clexane. And with enoxaparin, you can put them, we can start them as an outpatient on the clexane. Usually our thrombosis nurses do that. We don't bother doing it ourselves, or admit them to hospital unless they are really bad. They are started on the subcutaneous heparin, which they take in therapeutic doses, and on the day of the colonoscopy, they are advised not to inject themselves. So we do it more on an outpatient basis because you avoid, but you are perfectly right. You can do it with intravenous heparin. That is the classical way of doing it, right? So it is always risk versus benefit. At the time when he was bleeding and they did not know what the pathology was, the colonography was the sensible procedure to do. Now they know he's got a problem, he needs a polypectomy, but it's going to be a challenging polypectomy. It has to be done by an experienced colonoscopist to minimize the risk, because if you get a complication from that polypectomy, surgery will be a major undertaking in him. So that will be a very high risk surgery. Antibiotic prophylaxis nowadays is not given routinely for valvular heart disease. It can be given in this case particularly because it has got prostatic heart valve, or if there's a previous history of infective endocarditis. Otherwise, like in the past, we used to give it routinely for any murmurs or anything. That's not practiced anymore, because the incidence of bacteremia during a colonoscopy is only about 5 to 6%. Whereas when you are brushing your teeth, it's about 30%. So colonoscopy is comparatively safer than brushing your teeth.
Even in the polypectomy, large polyps are being removed.
Pardon?
Even in the polypectomy, when large polyps are being removed.
Yes, yeah.
Even if they are being
Yes, you still don't. Yes, yeah, that's not in part. In his case, one can argue that if he's got a prosthetic valve, then you can use it, but the BSG guidelines on it is not to routinely use antibiotics. Right, now with the, sorry, I missed, yeah. There are certain procedures which are high risk and certain conditions which are high risk and low risk, right? So high risk conditions for thromboembolic events are atrial fibrillation associated with valvular heart disease, mechanical valve in the mitral position. Aortic valve, prosthetic valves are not such a high risk for thromboembolic event, not for bleeding. Mechanical valve and previous history of a thromboembolic event is a high risk, right? Procoagulable state due to anything like, yes, antithrombin C deficiency or any of those, and within 3 months of DVT, PE. Because in those cases, if you stop the anticoagulation, there is a risk that they can have thromboembolic event. Low risk are DVT or PE from more than 3 months ago, uncomplicated or paroxysmal non-valvular atrial fibrillation, AF with a normal heart valve, bioprosthetic valves, and mechanical valve in the aortic position. So they are low risk. You do not need to anticoagulate those patients. The one above, you need to. Low risk procedures are plain colonoscopy. I mean, if that patient did not have a big polyp and if he needed a diagnostic colonoscopy, in that case we would not have stopped the warfarin or the start him on heparin. The reason for that is that even if a patient is on warfarin and his INR is therapeutic, that is 2.5 to 3, you can still take endoscopic biopsies safely. There is no contraindication to it. But you cannot carry out polypectomies or sphincterotomies. So low risk procedure, diagnostic procedure, ERCP, just stenting, not causing, you can continue with the warfarin, but keep it below. High risk procedures, polypectomy, sphincterotomy, EMR, any of the dilatation of strictures, therapy of varices, anything, in those cases you follow that. If they are on warfarin, like high risk conditions which are prosthetic, which we just discussed, prosthetic mitral heart valve in mitral position, those conditions, stop warfarin 5 days before procedure, start them on low molecular weight heparin 2 days after stopping warfarin, and as we discussed, right? If there is a low risk condition, stop warfarin 5 days before endoscopy and carry out the endoscopy. Any questions on that? That's what we discussed basically, we do, yeah? Right, case number 2. 21-year-old woman with a 4-year history of intermittent diarrhea and severe lower abdominal pain is seen in the surgical clinic. On direct questioning, she admits to abdominal distension, rectal dissatisfaction, and the passage of mucus PR, which is She is referred for colonoscopy. She is anxious and requests a general anesthetic. How would you proceed? Yeah. I mean, first of all, it's a bit unfair. They've written surgical clinic. The indication is not very strong for doing a colonoscopy in this type of patient. She's a typical irritable bowel syndrome patient. She's only, abdominal distension, rectal dissatisfaction or sensation of incomplete evacuation, and passage of mucus PR. So there are no alarm features there. They do not even point to a diagnosis of inflammatory bowel disease. It is a young woman with, cramping abdominal pain due to irritable bowel syndrome. So, and on top of that, if you perform a colonoscopy with a general anesthetic, you are exposing her to extra risks. So the indication should be seriously looked at. That's why they've written surgical clinic.
While we are at it, I think it's important that we have somebody from the pediatric department. I would like to hear other people's opinion, but we never, and I use the term never, perform any endoscopic procedure in pediatric without propofol or general anesthesia, without anesthetist giving it. The anesthetist has to evaluate the child and has to flatten the child for me to do any procedure, whether it's basic diagnostic gastroscopy or colonoscopy. I personally feel it's almost criminal to do colonoscopies in young girls without propofol or general anesthesia or whatever the anesthetist feels is the best. Patient should not know as a child anything except putting a camera. That's my opinion, but I don't
No, I entirely agree with you, but I would just add a proviso there that colonoscopy should be performed by an experienced colonoscopist, because when we are doing colonoscopy, the pain that the patient gives you is an indication that you may be pushing in too much or too hard, and that should always be used as a measure of how hard you are pushing. When you give somebody a general anesthetic, that is lost, and if a endoscopist is not very experienced, he'll just push in ruthlessly and recklessly, and that can cause a tear in the mesocolon or in the colon. So that's why colonoscopy under GA is dangerous in inexperienced hands. It should be performed by your best colonoscopist if you are doing better.
by 2/4 in pediatric.
Yes, especially. So that is the message, not that you do it. Yeah.
We will finish the case 2
Yeah.
and then come back to cases after because we need to move on with the next
Okay, fine.
lecture.
Yeah, because it was a filling. So I thought
we'll
yeah.
finish the rest of the cases. You had 4.
I think there may be a few, yeah, but we can leave those. Yeah.
Coming back.
This was just a bit of a
Yeah, we'll
filling.
keep coming
Yeah.
back to the wherever we
Right.
have
Okay.
slot,
So you
we'll
want to
just
do
go
the
back. So
next
we
item, yeah.
request,
Paul to.
Paul Hagen to come and
do
tell
the-
us principles of colonoscopy and scope handling. Thank you.
Yeah.